Good afternoon to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned professor, Dr. Manoj Kumar Rohit. Sir is MBBS, MD, DM Cardiology, professor at the Department of Cardiology at Postgraduate Institute of Medical Education and Research, Chandigarh. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is Transcatheter Aortic Valve Replacement Update. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir. Sir, the session, we are live, sir. You can start, sir. Hello?
Yeah, I'd like to thank. Hello, can you hear me, Shreya?
Yes, sir. Yes, sir. We can, sir.
I'll just make a full side.
Sure, sir.
It's a great honor and privilege to be part of this group to give a lecture. I'd like to thank Shreyan and IJCB group for giving this opportunity. Today, I'll be speaking on TAVI, what's new in TAVI and what is there in updates. So there has been aortic stenosis is estimated to in about 7% of the population over 65 in United States of America. I'll come to about India a bit more. So it is more likely to affect men than women, and almost about 80% data from US says that 80% of adults with symptomatic aortic stenosis are male compared to women. One needs to understand that once you diagnose aortic stenosis, many of the patients are asymptomatic, and we need to educate them that once they develop symptom, the survival is significantly reduced. Suppose they develop onset of dyspnea, they are not going to survive more than 5 years. Suppose they develop syncope, then they are not going to survive more than 2 years. Similarly, they develop angina, they are not going to survive more than 3 years. So three cardinal symptoms of aortic stenosis are angina, syncope, and failure. If almost about 50% of the patient who develop aortic stenosis with failure will die within 2 years of onset of symptoms. So when you read the echo report, what you have to look for two important parameters. Jet velocity is important. If you have see the jet velocity is written as a more than 4 meter per second, that indicates severe aortic stenosis. And if it's more than 5 meter per second, then it's a very severe aortic stenosis. Second parameter you have to look for is what is the wall area. If the wall area is less than 1 centimeter square, then combination of the jet velocity of more than 4 meter per square and wall area less than 1 meter second indicate severe aortic stenosis and warrants therapy. Similarly, if you have a jet velocity of more than 5 meter per second and wall area less than 0.6, it will be very severe. Even if the patient has no symptom, should be have an intervention. We'll discuss about that. So there is a lot of another increasing TAVI has made this what is called possible aortic stenosis or not possible results. There is a gray zone where the patient ejection fraction is below 50% and the patient's wall area is less than 1, but gradient is not very high. We say when a gradient is more than 40, a mean gradient of more than 40, it indicates severe. There is no confusion about that. But suppose you have aortic stenosis whose moderate ejection fraction is low and gradient is less than 40, and then how do you decide about this? Is it severe or not? So there are multiple things we have to do. We have to do is echo. Not only is typical symptoms, is the age, is the patient has a hypertrophy, then is the longitudinal strain reduced. So basically, newer modality can be used, and you will invariably find that mean gradient won't be 10 and 20, it will be between 30 to 40. And calcium score increasingly along with echo, calcium score has become very important in diagnosis of moderate aortic stenosis. So if you have a borderline, if you're not sure if the patient warrants a therapy, probably you can get a repeat echo done with a dobutamine stress echo. And if the dobutamine echo stress echo shows increase in gradient without reducing wall area, probably you're dealing with a true significant aortic stenosis, even though gradient does not fulfill the criteria for severe aortic stenosis. Top of that, now calcium has become very important assessment in assessing severity. If there may be occasion where echo does not give a clear answer, then you may get a plain CT scan to see what is the calcium. It is said that calcium score of more than 3,000 in men and calcium score of more than 1,600 in women are likely to predict the patient to have a significant severe aortic stenosis. So why are we talking about TAVR and not surgery? Risk of surgical valve replacement increases with age and comorbidities. There are almost about 30% of patients who are unsuitable, who have severe aortic stenosis, who are symptomatic, but simply not suitable for surgery. The surgery cannot be done in such group of patients. Another 30% are very afraid to get their chest done, open heart surgery done. So there is a fairly good amount of patient population who will not seek, who has confirmed diagnosis of aortic stenosis, and who does not want or who are not eligible for surgery. And out of this, 2 million population in India. And of this, and if one understands that almost about this disease is rather bad, as worse as their metastatic cancer. So there are patients who are very clearly requires TAVI compared to surgery. If the patient has a favorable axis, we will talk about why we are talking about transfemoral. If the patient has a transfemoral approach, a TAVI, then TAVI is preferred over the surgery. If the patient does not have a favorable transfemoral axis, then surgery might be preferred option. Also, the patient has a sequelae of chest radiation, then patient requires TAVI. If the patient has a porcine aorta, then TAVI is preferred surgery. Presence of bypass surgery, sternotomy, and repeat due surgery is a difficult situation and may prefer TAVI compared to the surgery. Surgery often leads to prosthetic mismatch. That means the patient requires a bigger size valve, but you are unable to put a valve. There are a lot of centers who do not have expertise to enlarge the aortic root, and aortic root enlargement is required to put a proper size of aortic valve surgery. So a lot of, if you don't put a proper size of the aortic valve, then you get mismatch. That means you will not able to reduce the gradient across aortic valve, and you will have hypertrophy. And so this is significantly better advantage with the TAVI compared to SAVI. So all those things patient should are preferable for TAVI. Which are the patients which are good for the surgery? If you do CT scan for TAVI, and if you find that coronary heights are low, say less than 10 millimeter, or the site of annulus is root are significantly dilated, or we have a limitation in the TAVI, inform that only about say particular size one is available, and the size is much more, then probably surgery are there. And presence of thrombus in a left ventricle dysfunction would warrant surgical very clearly. Also, if you think of a patient has a double wall disease like mitral valve disease, and then naturally TAVI alone is not difficult, but more and more cases are being done with a mitral annular calcification and TAVI and mitral valve. Patient has a CAD which cannot be treated percutaneously or warrants a surgery, would require a surgical intervention. And the patient has a significant structural disease, again would require a surgery. Patient has aneurysm of the aorta, would require a surgery, and so is a septal hypertrophy. So this is the man who introduced this novel and ever-expanding technology, Dr. Alan Krieger. He introduced in first human TAVR was done by him in 2002. So these are the two landmark trial which introduce the pathway commercial available trans-aortic valve replacement in this. That is a partner trial investigation was done in the two arm. So the patient who this partner trial evaluated about almost 3,000 patients, and in that the two arms are there. One patient cannot be operated. There is no scope of operation. That is inoperable. This about 350 patients were taken for TAVR to transfemoral approach, and some of this 179 underwent TAVR, or 179 did not undergo TAVR. So that means they continue on medical therapy. We'll talk about the result of this. In other high risk group where surgery was significantly high risk, but they were randomized to transfemoral and transapical. That means versus the surgery randomized was done. We can clearly show that partner trial paved the pathway for introduction, commercial introduction of the trans-aortic valve. Death from any cause or death from all cause were similar in a surgery versus transcatheter over a long-term period of almost 2 years. Transcatheter was far better in immediate period compared to the early surgery in this. There is and death from any cause in the transfemoral placement was lower to begin with, but overall, over the next 2 years, it shows a similar result. It is interesting to note that why we keep on talking about TAVI can be done transfemoral. This is because of this slide, which shows very clearly that if you do TAVI from transapical, that means thoracotomy and then valve, that has a rather worse outcome than a surgical outcome compared to that. That is why, if as and when feasible, TAVI should be preferred. Currently, people make attempt to prefer femoral approach rather than other approach. There are other approaches available. And the other trial from partner, if you do not operate TAVI, and if you do medical therapy, very clearly showed that TAVI is far superior from all therapy in form of all-cause mortality, stroke, and everything was superior. So these two trials paved the pathway for introduction of the TAVI. So how about India? We talk about the USA. It is estimated that almost about 2 million people of aortic stenosis are available. Unfortunately, only 15,000 underwent mechanical valve replacement. Out of which 4,000 tissue valve were there. In 2021, 1,000 patients underwent TAVR in India, and this number increased significantly in 2022 to 2007. So it's expanding there. Almost about 8,800 centers are available currently when the slide was prepared last month, and TAVR centers about 190. They are ever expanding, and the scope is tremendous there. So reimbursement is a big issue, and more government, other agencies are coming forward to introduce this therapy and coming. People are also not aware that valve can be placed percutaneously, and hence this is today's symposium. They have IJCP group has arranged for this. Affordability remains a big issue. The cost is slowly coming down. Previously, maybe 2 years back, it would be very expensive. Now the slowly cost is coming down. It's still expensive, but it is coming down to fairly good extent, I would say. So in 2012, the core valve was first commercially introduced. Over the period, the valve technology has significantly improved, and now we are getting better and better valve are being introduced, and we are going to say Medtronic is going to introduce 2024. I will share my two cases and then further data about this. This is my patient who has one of the two important complications of TAVI people talk about is the need for pacemaker. There's a fairly higher percentage of requiring pacemaker. This has, over the period of time, slowly, significantly reduced, and I will demonstrate in my patient how this TAVI. We were lucky and we were fortunate that technology has made it feasible, and number of pacemakers are good. So, in my patient who has a left bundle branch block and a low flow aortic stenosis gradient, so he's a 72-year-old male, no hypertension, no diabetes, and he has angina, distal exertion, normal axis, and ECG shows left bundle branch block was there about 148 millisecond. He was significantly class 3 symptom of dyspnea and angina was there. Severe calcific aortic stenosis were there. He's a heavily calcified aortic valve was there. He had a gradient of 5326 borderline gradient, but aortic valve area was 0.7 centimeters square, and ejection fraction was low. So this aortic valve was responsible, and we demonstrated by dobutamine. For want of time, I have not included dobutamine on this. So we did angiography for him, and we offered him that you should go for, you have 2 lesions, and so was surgery. Unfortunately or fortunately, he was aware of the technology and he refused to undergo surgery. He said, do stent and then we'll see and then decide. So he underwent PCI in February 2020. However, despite the PCI, his symptom persisted, and then we needed to address his aortic valve. So we did a CT is a mandatory requirement for doing percutaneous aortic valve replacement. Of course, our surgeon also gets CT scan done for sinus, coronary measurement, and all this thing. So CT is very simple way to measurement, and where you have to see what is the annulus, what is the sinuses, coronary height are there. So in this patient, the coronary heights are fairly good, and the annulus we were able to develop. So based on the CT, we decided to use a 29 millimeter Evolute Pro bioprocessors from Medtronic. So he had undergone angioplasty. So we did one check shot that stents are flowing. You can see the stents are flowing very well. Then the second stage we have mounted the Evolute Pro valve, and you can say that valve is fairly well mounted. Is there? When doing the procedure, crossing the also makes difference. So this is one cine which shows crossing the valve is there in the arch, which embolism can occur, and this is we are deploying the valve with a rapid pacing in this, and then you can see the valve has been deployed successfully, and you can see this is no AS and no AR is there, root injection. So this is a fairly good result for him, and he was discharged because of a left bundle branch block. We kept it TPA for 24 hours, and we observed him for 24 hours on temporary pacemaker. Normally, temporary pacemaker is removed on table, but because of left bundle branch block, we observed with him, and you can see that this valve did not damage his conduction system, and the ECG did not change. ECG remained the same thing. Aortic valve gradient came down significantly with a mean gradient of 7. That's probably difficult to expect in a surgical valve replacement. That is feasible on the lower gradients are feasible in a TAVI approach. So 2 issues in this low flow gradient, because our patient had ejection fraction of below 50% and gradient of below 40, mean was below 40, but aortic valve area is so. It would classify as a low flow, low AS gradient, and this TAVI made this ejection fraction significantly well. The other problem in this patient was the pacemaker, need of pacemaker. Since he did not have a change in ECG, and there was no high degree block, no new onset bundle branch block, and was there, we did not deem appropriate to think that he required a pacemaker, and also the QRS, which was below 150 millisecond, there was no change at all. So we did not perform his EPS study or any ECG monitoring was there. He was of course kept in ICU for 48 hours. So there was no need for a pacemaker in his individual. Other subgroup which is significant is the severe aortic stenosis often have coronary artery disease, And this is one patient, a very sick patient, 65-year-old lady, hypertensive and CKD on peritoneal dialysis. She had opted for TAVI a year back. Unfortunately, for some unknown reason, they did not underwent TAVI that time. And it's a progressive disease, malignant disease, and so progressive shortness of breath since 1 month. She presented to us with this episode of syncope, and you can see ECG is fairly hypertrophic. She had a severe calcific aortic stenosis with an ejection fraction of 25%. At that, have a grade of 44-24, a severe thing, and she also developed MR. So we had her CT. We went in with the same previous CT which was there. You can see the severe calcific aortic wall there. Coronary height was also fairly good. There was no ocean. And when surgery was simply not possible because she was in pulmonary edema, and she had gone into renal failure, and she had to do a dialysis to stabilize her and put on an NIV for ventilation. So angiography was done, and you can see the critical stenosis in LAD and critical stenosis in RCA, and of course LCS cut off. So this was the family, and we offered them, spoke to our surgeon, but surgery was very high risk. So we decided to perform a PCI on the table and then perform the TAVR. So PCI was performed successfully from LAD with a minimum contrast, and IVAS guidance was used to say, then a fairly good result. And then we performed wall under general anesthesia. Ventilation was she was ventilated because of the pulmonary edema, and she tolerated the procedure fairly well with shifted to CCU and hemodynamic stabilization. There was no conduction abnormality. Post almost zero. You can say about 4 was there. Trivial leak was there. We did not expand this because the calcium was very heavy with that. So calcific aortic stenosis CAD is a significant problem, and more. So what should be done? In a study from STS registry, almost 60% patients of the undergoing TAVI have a significant CAD there. The source, France TAVI and German registry had shown CAD to be higher mortality. However, UK TAVI and advanced do not show independent predictor of CAD in this patient. So if you have a patient of acute MI, left main, proximal disease, then it is better to perform angioplasty, wait for a few weeks, and then perform TAVI electively. So you don't have to difficulty in accessing coronary access is there. But on other hand, if you have a normal patient has other issues, then you can perform the TAVI and SAVI together as we did this. So what's new in TAVI? We need to have a valve, currently available valve do not last more than about 8 to 10 years. We need to have a durable valve, one valve for a lifetime, which is being developed, which will take time. And unless we test and we demonstrate, we will take time. Lower profile valves are required. We require a long sheath. We require 2 device closure for femoral. Femoral access, the injury often postpones the procedure, and so will there. And we need a valve which is fully retrievable. So there are groups of patients, challenging group of new patients, which are more and more will undergo TAVI in future. One of them is bicuspid valve, peculiar to Indian setup, moderate aortic stenosis with LV dysfunction. TAVI, one patient who have one TAVI will have degeneration because valve does not last more than 8 to 10 years, currently available, and asymptomatic severe aortic stenosis and aortic stenosis. So I will just say a few words about them. So what we know about TAVI in bicuspid valve, that it's a feasible and safe. 1 year mortality is similar to surgery. Better result with a newer generation valve. A CT scan is mandatory. If you are unable to diagnose bicuspid, CT scan will tell you whether bicuspid or not. And calcific raphe, highly calcific left heart, the poor outcome was there. So what needs to worry about it? It's there is a low risk of stroke in TAVI, but definitely higher than a normal tri-left valve. Higher risk of pacemaker implantation than a normal tri-left valve. Low but higher risk of annulus rupture is there in such patient. So it is a high risk category, but so that's why we are separately discussing this thing. But it's doable, and more data coming, and more studies are being performed to demonstrate feasibility, safety, and long-term outcome of TAVI in a bicuspid aortic valve. So the Western world does not talk about TAVI, in rheumatic isolated rheumatic stenosis in young age extremely rare. But it and rheumatic, unlike the degenerative aortic valve disease where you have calcium, the rheumatic aortic stenosis often has a fibrosis and may not have significant calcium. So anchoring of the valve may not be available, and other frequent multiple valves are involved, like tricuspid, mitral valves are involved. So very less population of the pure rheumatic aortic valve disease will fit into TAVI category. So is it feasible? Yes, people have demonstrated, and there is a study, a retrospective observation study, process feasibility TAVR on rheumatic AS, and they have demonstrated TAVR is feasible and doable in the rheumatic aortic stenosis. So there is a data as in one of my case, I showed you that patient has a moderate aortic stenosis, the aortic dysfunction does improve the quality of life. My patient is almost about 6 months now, and he's doing extremely well with a good outcome. So in the patient of moderate aortic stenosis with aortic dysfunction of less than 50%, mean referral, significantly reduced all-cause mortality was observed in TAVI compared to optical medical therapy. So this group does benefit from surgery or from TAVI, and one should not, because of the borderline doubtful gradient, one should not deny them any intervention is there. So there are further ongoing trial in this to answer the question. This better on this. More and more patients will come wall-in-wall. If you have a wall-in-wall surgery, second surgery is always high risk compared to the TAVI. So there is a high risk of them. So stroke, MI risk are similar. Wall-in-wall significantly lower rate of pacemaker implantation, and higher post-op gradients are there in wall-in-wall. So in this one of the study done redo TAVI in 2021 published, Evolute Pro was used in 2090 patients with a 94% success rate and 2% hospital mortality. So the Evolute Pro has demonstrated fairly good outcome in a wall-in-wall therapy is there. How about a lot of patients are asymptomatic? We need to convince them that asymptomatic patient can have a sudden death. A sudden death does occur in asymptomatic, and once the patient goes to severe aortic dysfunction, the procedure increases, and the patient, or not all patients of aortic dysfunction, will recover from completely. So in a patient asymptomatic severe surgery or intervention is clearly indicated if the patient has developed ejection fraction below 50%. There is no confusion. And this surgery is clearly indicated if the patient has severe aortic stenosis, and so abdominal exercise test is there. Also, should you think about the surgery should be asymptomatic patient, severe aortic stenosis, and is there, then the TAVR should be done. There is a very severe aortic stenosis, what is defined as a velocity of more than 5 meters per second and value of more than 0.6 would qualify there. The asymptomatic TAVR in the Evolute Pro has done 138 patients and showed comparable clinical outcome with a high all-cause mortality was there. And there is another ongoing early TAVR data with SAPIEN 3, and SAPIEN 3 Ultra was there, is going on. So I think fairly good data is available of TAVR, and fairly good number of TAVR have been done in aortic stenosis. What about severe aortic regurgitation? Those patients who are not eligible is there. Challenges are the severe AR patient currently. Please remember, do not send all patients for severe AR for TAVR. Currently, it is standard of care is surgery, and we need some more better valves and better technology to change this category from surgery to valve. It will take some time, but more and more work is being done. So what is the challenges? It is a larger annulus. There is insufficient calcium to hold the valve. Valve may not hold, and it may embolize. So surgery is the currently treatment of choice in the ejection fraction less than 50% and volume less than 10%. Some patient may be high risk for surgery, and when surgery is prohibitive or not being done, only those cases we can discuss to your referring cardiologist for this possibility is there. The core valve is most widely studied in this patient. The newer generation valve have shown less malposition and less cardiovascular morbidity compared to. So currently, TAVI in severe AR should only be done if the patient is inoperable and off level, should not be used. More newer specific valves are being developed to TAVI in severe aortic regurgitation. So coming to the data and the strategies in Western world is shifting towards more and low category.
Hello. So am I audible to you? Hello. Sir, your video got stuck. Dear viewers, let's just wait for some time as our speaker is facing some technical issues. Thank you. Sir,
Yeah,
you're
sure. I'm
yes.
sorry.
No, sir, it's absolutely fine. Thank you, sir.
So this is Notion trial has very clearly told
Sir,
us
your camera
that
is off, sir. Sorry to interrupt. Your
okay.
camera is off, sir. Please switch it on.
Yeah. So this study will be TAVR versus SAVR Notion trial, all cause mortality. So about 250%, 280% were enrolled for the 145 in TAVI group and 135 in SAVR groups were there. The very age was almost similar. TAVI group was 80, SAVR group was 80. STS score was about very low risk, but the patient can both easily undergo TAVI or surgery was there in this patient. So we can very clearly see this death curves at that long-term outcome, all-cause mortality, myocardial infarction, and stroke were similar whether you perform a TAVI or a surgery. Is there in this finding? Again, all-cause mortality and other complications 10 years were almost similar from cardiovascular death, stroke, ischemic attack, MI were almost similar in this case, and new need for permanent pacemaker were almost similar in this patient there. The structural wall deterioration is a major issue in bioprosthetic wall. The mean grade of more than 20 would worry about it, and then severe AR would be worry about it. And you can see from this slide, Notion trial demonstrated that individual who undergo TAVI has a better biprosthetic valve maintenance compared to surgical valve is there. You can see deterioration at 10 years in TAVI group was 20% compared to deterioration in a surgical valve was almost about 37%. So biprosthetic failure was about 10% in TAVI group and 15% in a surgical group is there. So another trial presented recently in the TCT 2023 Evolute trial, and you can show that the amount of TAVI done in the US is absolutely unbelievable. A number of they're doing, and the more and more data being generated is there. So TAVI is increasing, and surgical groups are reducing more and more is there. So what did it evaluate? It evaluated 4-year clinical and hemodynamic outcome with TAVR and SAVR in a patient from Evolute Row series trial is there. So what 1-to-1 randomized was done for surgery versus TAVR in the low risk group. At end of the 4-year data is available. We can say 4-year TAVR available 94%, while surgery has a below 89% follow-up data is available. We can see very clearly the mean gradient was more than 20 was very low. Mean gradient was extremely good in TAVR compared to the SAVR group, and so is the severe paravalvular were also very low in Evolute TAVR group compared to SAVR group. So in the primary end group, you can again see that the patient of 4-year outcomes was far better in a TAVR, Evolute TAVR compared to the surgical group. Similar all-cause mortality was also better with a TAVR Evolute TAVR compared to the SAVR group was there. This curve clearly differentiates this. Even in the low risk category where surgery is feasible, TAVR will come once we have a durable and long-term valve is there. So this trial in the low risk shows that 26% reduction in hazard of death from disabling stroke with Evolute TAVR compared to surgery at 4 years, significantly lower mean gradient with effective orifice, which determines the long-term outcome in Evolute TAVR group. 85% Evolute TAVR patient had none paravalvular leak, and there was no difference between a moderate and greater paravalvular leak was there. So this showed excellent safety data and encouraging data to subject in TAVR enrollment. So TAVR is the future. We will continue to see this technology in India also. As was shown on slide, that the number of TAVR done in US is simply beyond our imagination. We will also see more and more being done in India. Long-term durability is important issue in Indian setup because of costing. More and more devices, new devices are being tested for durability, and more we will get devices which will last fairly longer. Is there structural VAR deterioration is an issue, and this needs to be addressed very clearly, and it is important when you subject patient for surgery versus TAVR. If you have a borderline doubt, and then a surgeon is not confident of aortic enlargement, then it is better to have a TAVI perform than SAVI is there. So orifice area is important, is there, and evidence-based approach in aortic stenosis is more and more in favor of TAVI compared to SAVI is there. And once again, I'd like to thank Sriyan and IGCP group for giving me this platform to express my view on TAVI. Thank you so much. Thank you.
Thank you, sir. Sir, we have few questions from our audience, if you'd like to take that up.
Okay.
Sir, the first question is, how does TAVR impact the quality of life and functional outcomes in elderly patients?
Oh, so I have a few of my patients who have been operated at late, say not at you can say basically in 90s year. So, but two of my patients I can very clearly say 90-year-old gentleman who had a severe aortic stenosis, and he was going to repeatedly into failure, and he's simply not able to think. We did TAVR for him, and he's significantly, he's now after the TAVR, he's able to do his normal day-to-day activity without it. So his quality of life is definitely better. There is no confusion about that.
Thank you, sir. The next question is, what are the most promising areas of research in TAVR, and how might they shape the future of aortic valve replacement?
So as I said, there are a few interesting areas research is going on, and what is going to happen? Are we going to replace AR also with TAVR? That is the one research is going on. We currently do not have a good valve which can be used to percutaneously to do TAVR in AR. So that is the one group. Then also research is going on into the aortopathy. You have Indian setup has a lot of young bicuspid valve. The bicuspid valve has not only a valve problem, it also has a dilated ascending aorta, aortopathy. That is going to be people are working on it, and research is going on what valve, and complications are a bit more in the thing. Can we do better valve for a bicuspid valve? Is there in such a scenario work is going on? And third issue would be, I think, duration. In Indian setup, young people TAVR doing and 10th generation is not good. So we need a valve which is better durability. So I am not. We don't have currently the data. I'm sure Medtronic's Evolute Flex is coming up. We'll see how they are doing it. But in a surgical blunt, what is Resilia from Edwards is estimated to a very long life biprosthetic valve. Similar valve, I'm sure, will come into this. These are the three very promising area of research going in TAVR group in future therapy.
Thank you, sir. The last question from our audience is, how effective is the vulva-in-valve TAVR approach, especially in the addressing prosthetic vulvar degeneration?
So I had very limited data is available, but whatever limited data is available, valve-in-valve area is a fairly limited data. Whatever is available, it's a fairly good result is being shown is there. But we, as the question is very pertinent, more and more patients are going TAVR compared to SAVR in valve, and they are showing good results. So we have to achieve a mean gradient of below 20 and effective orifice area of more than 2 centimeters square, which current generation valves are able to achieve that.
Thank you so much, sir, for joining us today. Before concluding today's session, any last remark from you, sir?
Shriyan and IGCP group, thank you so much for giving this opportunity to share this platform of a new, exciting, promising, and the new technology which is going to stay for a long time, and at least next 10 years. So once again, I thank you so much for Shriyan for giving this opportunity and bearing with me and coordinating with me. Thank you so much.